Hello, my name is Ashley McDowell. Thank you so much for giving me the opportunity to discuss this vignette, which for me has been phenomenally educational. I'm excited to talk to you all about a case of smooth muscle tumor with intracaval and intracardiac growth. Before jumping right into the case, I'd like to discuss a bit of background. Whenever we encounter intracardiac masses, we think about metastatic tumors being a component of our differential. Most commonly, these tumors are arising from the lungs, breast, or kidneys. There can additionally be metastatic spread to the heart from melanomas and lymphomas. The metastasis itself can occur one of many ways, including hematologic dissemination, direct local invasion, or propagation of the tumor from more distant sites via the caval system. The case I will be presenting today will illustrate the occurrence of a histologically benign gynecologic tumor with caval propagation to the right heart. So let's move on to the case itself. Our patient is a 44-year-old female who actually initially presented to her primary care physician looking for a prescription strength antacid, which she thought might help with some progressive abdominal bloating that she had been having for the preceding 4 to 6 weeks. Her review of systems was negative, except for the finding of a 17-pound weight loss over the past 6 months. Her primary doctor sent the patient to the ED for further evaluation, where an abdominal mass was seen on initial imaging. Her presentation ultimately intersected with my own team when she was admitted to the hospital for further evaluation. Her past medical history was only notable for her OB history, which included 3 prior gestations. Her family history was notable for fibroids in her mother, prostate cancer late in life in her father, and lung cancer in her grandfather, who was a heavy smoker. Her social history was relatively unrevealing, and her medication list only included an over-the-counter vitamin D supplement. On initial presentation to the hospital, the patient was noted to have normal vital signs. Her physical exam was remarkable for a soft, non-tender distension of the abdomen with central supraumbilical mass. She had a negative fluid wave and no stigmata of liver disease. Her laboratory evaluation was relatively unremarkable, with a negative beta-HCG and transaminases within normal limits. We ultimately sent several tumor markers as well. Her CEA and CA19-9 returned within normal limits. Her CA125, a tumor marker typically seen in ovarian and endometrial cancers, returned elevated. She underwent several different imaging studies, which included both a CTA abdomen pelvis, as well as transthoracic echocardiogram. As I scroll through the CT within the axial plane, notice these areas of filling defect within the IVC. We'll see it again as we move distally, here. And then as I continue to scroll distally, we'll be able to appreciate this large cystic component of the mass, measuring 24 by 12 by 16 centimeters. As we move even more distally within the pelvis, we can recognize this heterogeneous portion of the mass with mixed solid and cystic components. That portion measured 13 by 13 by 12 centimeters. So given that there was vascular involvement to this mass, as noted by the IVC filling defects on imaging, she underwent transthoracic echocardiography. Here in this image, taken from the peristernal short axis view at the level of the aortic valve, we can see a multilobular mass extending from the IVC into the right atrium. Here on our second image, again at the peristernal short axis view at the level of the aortic valve, we can see that the mass measured 5.6 by 1.6 centimeters. Given these imaging findings, we had substantial concern that there was a malignant process driving this presentation. As with most cases with concern for malignancy, tissue became the issue, and with the help of many surgical colleagues, our patient underwent surgical resection. The operation was incredibly complex and involved multiple procedures via multiple surgical specialists, all while on cardiopulmonary bypass. Intraoperatively, the mass appeared to arise from the uterine myometrium with extension into the venous vasculature all the way to the right heart. Following surgical resection, the specimens were sent to pathology. On gross exam, the mass was noted to be firm and rubbery with plug-like extensions as shown in these images, with the primary mass shown here on the left and the intracaval portion on the right. On microscopic exam, the resected tumor showed histologically benign smooth muscle cells consistent with the diagnosis of intravenous leiomyomatosis, or IVL. So let's briefly discuss what IVL is. Leiomyoma are the most frequent neoplasm in the female genital tract, consisting of smooth muscle cells. IVL is a rare variant of leiomyomatous disease in which there is a characteristic vascular extension, which may extend as far as the cardiac system, as seen in our case. By nature, IVL is histologically benign. However, it can present in an incredibly clinically aggressive manner with potentially life-threatening consequences due to its propensity for vascular extension. IVL presents in a highly variable way, and the symptoms of IVL are easily confused for other potential etiologies. As in most cases, tissue is necessary for diagnosis of IVL. However, in the preoperative timeframe, it is imperative to adequately examine and delineate the extent of disease with imaging. Cross-sectional imaging can be helpful to assess the full extent of tumor burden and to better suggest the likely origin. Echocardiography is essential for the assessment of intracardiac involvement. Because of the vascular invasion and potentially clinically aggressive presentation, IVL can be concerning, as in this case, for a histologically malignant process such as a leiomyosarcoma. Histopathologic analysis is required to both diagnose IVL and to differentiate it from other entities. So, in conclusion, I hope that when considering metastatic tumors as sources of intracardiac masses, that you might consider a diagnosis of IVL. If you are concerned for IVL, remember to obtain imaging studies in the preoperative period and that tissue is required for diagnosis and differentiation. Here are my references, which are fantastic reviews and case series on this topic. And thank you so much for your time and for allowing me to share this case.